Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Welcome to another episode of All Things Cardio-Oncology. I'm here with my co-host, Dan Lenahan. He's our regular host here. Dan, how are you today?
I'm great. Thanks, Steve. I'm excited to hear about one of my favorite topics, obviously, in the space of cardio-oncology. So we're going to talk about amyloidosis and some of the imaging characteristics. So really excited to hear what our Egyptian colleagues have to say.
Yeah, well, we are so glad to be joined by two of our friends originally from Egypt, both now working in the U.S., but Abdurrahman Ali is a fellow of cardiology at University of Texas in the Galveston area. So Abdurrahman has helped us with a number of projects at ICOS, so really glad you could join us today. How are you doing?
All good. Thanks for the invitation, and it's a pleasure to be with you guys here today.
Yeah. Well, he has introduced us to a friend of his, Dr. Ahmed Abuzaid, who is also, as I said, originally from Egypt. And we have a growing presence in Egypt as an organization. We certified our first center of excellence there this year. So really excited about the work that's developing there. And Ahmed is actually now working in Anchorage, Alaska, which is quite a far cry from his home in Egypt. He is an advanced imaging specialist with a special interest in amyloidosis, as Dan mentioned. Real glad to have him with us today. And I wonder, Ahmed, if you could just start by telling us a little bit about your background and how you got interested in cardio-oncology broadly and amyloidosis in particular.
Thanks, Steve. Hi, Dan and Abdurrahman. Nice to be here today. Thanks for the introduction. And yes, we have Egyptian presence in Alaska. It's far away, but I think this is where good cardiology and good practice take us by heart. I'm Sami Abuzaid. I'm a clinical cardiac imager. I actually grew up in Kuwait and then moved to Egypt. And then now I'm in the US. I finished my cardiology training back in Egypt and in Shams University, and then transitioned to the US. Repeated my internal medicine residency and cardiology fellowship, and I graduated from University of San Francisco, California in San Francisco, where I did my advanced imaging. And actually, I fell in love with thick hearts and hypertrophic cardiomyopathy and cardiac amyloidosis. And here we go. We started a clinic in Alaska where I run the clinic with my heart failure colleagues and the advanced imaging as well. And we started the first PYP scan about 5 years ago, exceeding 300 cases in Alaska, and it's just growing.
And Dan, I know this is, as you said, one of your favorite topics, so I'm going to turn it over to you to explore more with us today.
Yeah, I'm just curious, mainly because I don't know the answer to this, but the dynamics of amyloidosis around the country and around the world are dramatically different. For example, I was at Vanderbilt University in the past, which is in the Southeast, and we had a certain demographic that was more prominent in regards to amyloidosis. So the Scottish Irish heritage, T60ALA was the previous mutation, and that seemed to be more common coming from Scottish and Irish heritage. And then when I moved to St. Louis in the middle of the country, we had a much higher African-American population, and V122I was much more common. I'm just curious, is there a pattern like that in Alaska? And if there is, what is it? Is there some sort of regional difference in your practice than maybe some of these others examples that are brought up?
Yeah, actually, that's one of my questions as well when we started the program. And interestingly, we did have a lot of non-hereditary or wild type TTR amyloid, but surprisingly, we had a lot of families with genetic or hereditary amyloidosis. And I think the same genes that you mentioned, the VAL122, I think was really more common, as we know, in African American. but also we did find it in some native population. And I think you have to understand that in Alaska is a melting pot with a lot of people around from diverse background, but we did see the same gene in the native population as well, which is, I think, very unique. And the V30M as well was very dominant in few families. And I think we're just learning. And the problem with underdiagnosis of amyloidosis in Alaskan population, specifically with native population, they don't expose for early genetic testing in the process. And I think that's one of maybe the caveat that we've been seeing, but it's the same genes, but I think we try to be expanding the reach for the native population, especially in the native villages, because they don't have access to that. There's some barriers to that.
So I was kind of curious about that. I'm glad you mentioned the V30M because I believe that's the more common variant in Japan. And I didn't know how much migration happened to Alaska from Japan. And, V30M is probably most prominent in Portugal and also in Brazil. But as I understood it, a pretty high percentage, certainly of hereditary TTR being V30M is from Japan. Now, I may be misspeaking about that, but that's what I was curious. So you actually mentioned it. And is there a strong migration from Japanese area to Alaska?
Not much, but there is, but nothing to affect the population prevalence. And I think you're right. It's more common in Portuguese population, Sweden, Japanese. And interestingly, some of these native or indigenous population have peripheral neuropathy dominance as well. So it varies. Actually, I had a family have about 12 people positive for the gene V30M. And then 8 of them are just carrier, and then 4 of them are symptomatic and then on therapies, which is very interesting. But I think the Japan background, the Swedish migration, maybe the Finnish migration, maybe at some point have influence there. Unfortunately, we don't have published data for that. With the most recent HA statement many years ago with the native population, they did not really describe prevalence for indigenous population, what the genetic distribution, right? We hope that someday we're going to have some of this data, but it's going to take us some time.
That's really interesting. I think your main area of interest is about imaging, so I threw you a curveball on that one. But tell us about what your take on the whole imaging space. You mentioned that you started doing PYP scan not long ago and now are frequently doing it. It certainly is an old technology. Years ago was really used only for bone scans, but now has been sort of redesigned for a PYP scan to look for amyloidosis. So what's your thought there? What are your background in terms of that imaging technique?
Yeah, absolutely. And I think you mentioned it, the nuclear bone scintigraphy or the cardionucleotide amyloidosis imaging, or we call it CARI in nuclear cardiology. I think really modernize the way that we look into amyloidosis, specifically ATTR, right? I think this is one of the reasons with the cardiac MRI as well, with easy techniques, fast processes, that we can recognize cardiac amyloidosis earlier, right? That also with the increased awareness for cardiac amyloidosis and the available treatments. So we started to look earlier for that. And I think usually cardiac amyloidosis, when we think a little bit about it, we miss it because we don't think about it. But when you put it in the clinical picture with the red flags for the patient, it becomes very easy to find these cases. I think when I moved to Alaska, I think we have a robust cardiac MRI program, one of the busiest outpatient cardiac MRI programs, and we have lots of cardiac amyloidosis. But what the challenge is how we can put patient in the scanner and the lag time for the scanning if we're going to bring everyone for cardiac MRI. And I think at that time, that PYP scan started to be very hot topic, and all the guidelines been recommending that. So we started that about 5 years ago, and really the discussion, hey, we need to start PYP scan in Alaska, and just our management team helped us to make that happen. And now we're exceeding about 300 patients, and that's easy when you introduce that to practice, a busy practice like us, and educate a little bit our providers, physician, and mid-levels about, okay, what you think a little bit about unexplained left ventricular hypertrophy, what you think this patient have thick heart without hypertension, or with or without aortic stenosis. How about HFpEF, AFib, conduction abnormalities, and all the above, right? With the heart failure team. And then that become a very straight process to bring us to order PYP scan and utilize that technique in a stepwise approach, right? I think if we think about cardiac amyloidosis, we have to exclude AL amyloid. You do the blood work, you check your monoclonal proteins, SPEP, UPEP, immunofixation, serum light chain. And then if you have a clinical entity, then it's going to take you maybe an MRI at the beginning if you want to confirm and see things. But at the end, if everything is negative and you move to the PYP scan, you're going to have the diagnosis of ATTR cardiac amyloid, especially if grade 2 and grade 3. And it's funny, we think a little bit about how we change how we read the nuclear scintigraphy in the last few years. I think with the PYP shortage, we moved to HMDP, and that can be challenging, especially in Alaska. But I think with our techniques, we started to flip depending on the availability. Also, the way that we read the PYP scans, right? From the American Society of Nuclear Cardiology, I think the heart-lung ratio was really important at the beginning, and the planar imaging, and then we moved to be SPECT imaging, and now SPECT CT imaging, probably the best way to look into that, in addition to avoid the false positive and the blood pool. So I think it took us a little bit of post-processing skills with our technologists, with our readers as well, to get familiar with that and also with the indication. And I think it's as a team sport, how to incorporate your nuclear scintigraphy for amyloidosis in your clinical practice. And that was our story.
So Abdurrahman, when I was a fellow, which is many years ago, I think my memory may not be all that great, but I suspect that I never spoke about amyloidosis as a fellow. I mean, there might have been one case total. What is your observation these days in cardiology fellowship? Is something that we talk about a lot?
Yeah, absolutely. And then you always have to be vigilant for looking for a diagnosis, especially when your patients with HFpEF, like heart failure, African American, always look for them. And like, on daily, I'm currently in echo rotation, currently screening, trying as much as possible to pick up these features. And it's very interesting that if, like Ahmed said, if you don't think about it, you're going to miss it. And you always have to have high suspicion for amyloid. And therapies has advanced the care of patients with whether with ATTR or AL amyloid. And that's why it's important to be vigilant for that. Actually, what do you think, Ahmed, like behind your initial screening tool as an echo, especially like you mentioned, access to CMR, like when do you really jump to CMR right away once you see certain features in echo?
Yeah, absolutely. I think, first, the bedside clinical findings, right? The clues for the patient, right? I think we have already heart failure clues, like we think a little bit about HFpEF, low gradient aortic stenosis, intolerance to GDMT. Usually amyloid patients have intolerance to beta blockers, vasodilators. That's really one of the things that we see. As well, arrhythmia, AFib. I have a lot of amyloidosis at the beginning that been referred from the EP clinic, and I think this is important to recognize that. As well, brady or tachyarrhythmia, history of pacemaker. Now, patient also with polyneuropathy, painful neuropathy in the hands and the feet, muscle weakness, difficulty walking, falls, and there's a lot of patients, right? But also when you try to piecemeal all of these findings with some musculoskeletal findings as well, like carpal tunnel syndrome, ruptured distal biceps tendon, or Papai's sign, and now with trigger fingers, shoulder, knee surgery, all of that. So autonomic dysfunction like orthostatic hypertension, chronic diarrhea, weight loss, unexplained. So try to find how you're going to fit your patient, right? What symptoms, what red flags you think a little bit about. And then you look into the EKG, for example. Sometimes you have low voltage criteria, sometimes not. So now that I'm raised a suspicion of cardiac amyloidosis, and I think the first workup going to be an echo, right? And I think it's important in the echo that you're in the echo rotation. So paying attention to the wall thickness. Did we measure the wall thickness in an accurate way? Did we apply the diastolic dysfunction criteria? What's the tissue velocities? And most importantly, the strain pattern. right? And I think now we started to identify strain analysis with these things in a routine basis. And now LV strain is important. Left atrial strain also have implication with amyloidosis. But I think the introduction for cardiac amyloidosis and imaging has many years ago, but I think it took off once we introduced apical sparing pattern and strain in echocardiography.
So, I've kind of had this basic conversation with my cardiology colleagues, obviously, and, said if you saw this pattern, you at least need to be suspicious of amyloidosis. And that's a double-edged sword because on one side you say, okay, well, I see some suggestion of apical sparing that must equal amyloidosis. But, that is not exactly correct. What is your experience there in terms of if you have a pattern of reduced GLS, possibly an apical sparing pattern, how reliable is that for indicating amyloidosis?
Yeah, I think this is a very important topic. Think a little bit, cardiac amyloidosis is a restrictive cardiomyopathy as any other myopathic process, right? It can result in decreased tissue velocities and also reduce strain values. And that's where the specificity of apical sparing can be declined a little bit. Now, in the original study, many years ago, back in 2012, when the apical sparing was introduced, and compared to other diastology parameters, E to E prime, EF, ratio, deceleration time, global longitudinal strain with apical sparing have the best performance in terms of multivariate analysis and regression, right? And I think sensitivity about 93%, specificity about 82%. In this scenario, it does not really differentiate between AL and ATTR. It just tells you there's something wrong, probably hint you to an amyloid process because we spare the apex because all the deposition happened on the base. But also, in the same time, it should not fool you that other causes of apical sparing may happen. Other causes of left ventricular hypertrophy, like aortic stenosis, Fabry disease, hypertrophic cardiomyopathy. And also, it loses more specificity of these findings if you have a prior myocardial infarction or a case of pacing or conduction abnormality or chronic kidney disease. So you have to be aware about when are you performing the apical sparing in what patient. And I think not all apical sparing is amyloidosis, but the majority of them will be and gonna make you do the right workup at some point.
Yeah, I think in general, I would say an apical sparing pattern certainly indicates a cardiomyopathy. Then you have to figure out where that cardiomyopathy came from. So, for example, if you have somebody who has a pacing artifact, they could have an apical sparing pattern, or if they have some other myopathic process, it might cause the same issues. But certainly it's a marker. So it may not be absolutely sine qua non for amyloidosis, but it certainly is a marker that something is wrong with the ventricle and you need to pursue it. What about cardiac MRI? Where do you feel that fits into the equation?
Yeah, absolutely. I think when the power of a cardiac MRI tissue characterization, right? And you can do that with multiple ways, late gadolinium enhancement. And now we have parametric mapping with native T1 and ECV. Now, early in the process of cardiac amyloid, sometimes bone scintigraphy or nuclear scintigraphy can be negative. And sometimes the pickup of cardiac MRI can be positive early on. Also, the cardiac MRI can be a good modality to confirm the left wall thickness and try to rule out other phenotypes that we see with the same condition. For example, hypertrophic cardiomyopathy or Fabry disease or other causes for left ventricular wall thickness. So I think this is where cardiac MRI fit. And again, it will not distinguish between AL and ATTR. And I think that when your red flags become very prominent and you think about amyloid after your echo, either echo or cardiac MRI at that stage early on, this is where cardiac MRI will be very helpful at that point. Now, with the new therapies, we know that serial imaging can be very, how we monitor the disease progression. I think cardiac MRI maybe have an important role here when you measure your native T1 and ECV, and that on the long term, you can try to think a little bit about is are our therapies effective and have a role in stabilizing or decreasing the amyloid burden into the heart. But I think cardiac MRI comes early on the pathway, and then on the longer term, it can be repeated maybe in a year or 2 years, depending on the clinical situation.
Yeah, I mean, I think it's obviously a very powerful test. And I think ECV in particular is a documentable number that you can follow, possibly indicating treatment response. But of course, in order to do an MRI or to do an ECV, you have to do contrast. So, it's a little bit more detailed than MRI, and not every place that routinely does MRIs typically make an ECV measurement. So I think if you're worried about possibly amyloidosis, you need to indicate to your MRI technicians and readers that, yeah, now I'm interested in all these details, and the ECV in particular may be an important parameter to follow treatment response. I don't know if you agree with that or if there's any further insight you would have on that issue.
Yeah, totally agree. And also, if the patient have arrhythmia or devices, a lot of artifact can be there. But I think the technologists have to run the sequences and do the right measurement and be consistent in your measurement, especially for the ECV and native T1. You're measuring at the mid septum, at the base of the septum. And I think this is where the quality control of your lab will be important. And one another point about cardiac MRI that I think also can be handy, some hereditary cardiac amyloidosis can be negative in the uptake in the PYP scan or the bone scintigraphy. And now we've seen some of the cases when the cardiac MRI really have a little bit of a hint in imaging, maybe late gadolinium enhancement or a little bit abnormal ECV, where we could not see uptake on the nuclear scintigraphy. So I think that's also another value of the cardiac MRI.
So Abdurrahman, I would be curious to see what the current teaching is on this topic, but you know, especially in the cardiology world, we love to do interventions in one form or another. So TAVRs are super popular, and interventional cardiologists spend a great time and effort looking at details about TAVR and who's a candidate and then how to do the procedure effectively, et cetera. I would be curious, what is your experience at this point in time as to how often do they consider that amyloidosis may be coexistent in patients with aortic stenosis?
I think if you're heart failure trained, you always think about amyloid, at least from my current experience and my previous experiences. Like always, I think the heart failure specialist, like they're more oriented about, like we have to rule it out. We have to rule it out. We have to get the BYP scan. We have to take the extra strip and just get the CMR as an outpatient, even it's not going to be done inpatient. So I think, yes, there is a lot of vigilance and awareness about the diagnosis. And I'm actually thinking, in the future, like with the workflow, so at least you wouldn't be missing a diagnosis based at least on the echo images. What's the role of AI? Would AI in the future be giving you alarms in your EMR systems? Like, hey, by the way, this patient has these features. This is what the echo showed. This is what the clinical presentation is coming and showing, and then gives you a flag. Like, oh, this patient is suspected to have amyloid. So it's interesting to see how AI will advance the care of amyloid, but I think there's some efforts right now with a researcher clinical AMA, of integrating AI, and I would be interested in knowing, what do you think about that?
Yeah, well, I think we're contemplating, or maybe we're not contemplating, maybe it's being shoved down our throat, but the AI is interceding in every aspect of our work and society. So there would be no doubt that it's, somehow interposing itself in this equation. But one of the biggest problems is that, how specific is it? If you make an association between carpal tunnel and aortic stenosis and maybe hypertrophy read on an echo, and you say these three things together make it, 78% likely that you have amyloidosis or something like that. Statistically, that might be an important association to make, but once you put the the word amyloidosis into a patient's chart or into their mind, then you have to exclude it. And so a prime example is this past week, actually, there was a 79-year-old woman that had aortic stenosis and was being evaluated for a TAVR. And she heard on the radio that there could be some association between aortic stenosis and amyloidosis. And so basically she called the interventional team and said, "Can you tell me that I don't have amyloidosis?" And so my interventional team called me and they go, "What in the world do we do now?" So this is where, those AI techniques, they may catch some association that you maybe hadn't put together, but on the other hand, may indicate a lot of problems that may not be there. So I don't know what you think about all that in terms of how do we go about our day-to-day business in terms of when do we reasonably exclude amyloidosis and when do we not?
Yeah, I think it's an important topic. And I think with AI, maybe it makes the things a little bit easier, simpler. Like I think a little bit about it. Okay, if I have a tool that tells me maybe amyloid, maybe not, so I can start looking more into it, right? And some of the imaging techniques have an AI platform that really have high accuracy and specificity in the right hands, right? If you do the right echo and then tells you if there's ATT amyloid or not, right? But I think it will improve your workflow. That's number one. Number two, the urgency of the cases. That maybe this patient read in a couple of days and instead just waiting a few days to read the echo, and also detect the cases in a very big data set, like in the electrophysiology or the structural team, right? They're already doing the job, collecting a lot of data with the pacemaker and the history and the orthopedic problems and the past history. And maybe AI can take all of that and put it in a simple algorithm. Okay, considered amyloid evaluation. So this is how I see it, to be honest. And I think the human factor really is still going to be needed because these cases sometimes can be very challenging when we discuss with the patient and how we process and how we do the diagnostic algorithm for these patients, right? Now, that also AI can be very interesting if you apply that with the TAVR population, structural heart and aortic stenosis, right? I think we know that about 16% up to 20%, depending which data you're looking for, of AS patients, severe AS patients, have undiagnosed ATTR amyloid. And perhaps applying AI maybe can make that process a little bit easier in our basic clinical practice. So that's how we see the AI so far.
That's helpful. I'm glad to hear the human element is not going away. I think that's a true statement in all these areas. The technology can be helpful, but there are just too many factors that have to be considered. And we really appreciate your insights in this space in particular. This has been a fantastic conversation. We appreciate Abdurrahman being with us. Dan, thanks for your time. Ahmed, any last closing thoughts for our listeners?
Yeah, absolutely. Actually, I will close with this. Actually, the earliest known mummy to have amyloidosis from the Egyptian history was one of the called Princess Amun. And the interesting piece of it, when they did some of the amyloidosis degradation product and they analyzed the pathology, they found a lot of deposition, maybe not the perfect for amyloid because of the ancient history, but they found severe vascular calcification in the muscle and in the aortic valve. And amyloidosis being around for a while, for a long time. And I think maintaining high suspicion for amyloidosis in older adults, unexplained LV wall thickness, HFpEF, arrhythmia, it triggered you to look into it, think about the why and what you do next to find people early. So with that, I thank you all for having me today and looking forward to working with you again in the near future.
Super.
That's
Thank you
great.
so much. I guess the other message from what you just said is we'd like to catch amyloidosis before you're mummified.
Yeah.
Maybe.
Yeah. Good. Yeah.
And if you're not looking for it, you're not going to find it.
That's right.
That's great. Great to
All
have
right.
you. Thanks so much.
All right. You take
Yeah,
care.
thank
Thanks
you.
a lot.
Thank you.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.